Good afternoon and welcome to UMACO TV. My name is Kemal Erkan. This is our weekly event, and today is where we actually present our RCM modules, and collection is going to be our topic today. And Muriel Campos is going to be joining me. Sean also is here, and then we are going to cover a couple other topics after Muriel is done with her presentation on the collection module. So I'm going to let her in. All right.
Good afternoon, Kemal.
All right. Good afternoon, Muriel. How are you doing?
I'm doing well. How about yourself?
Very good. So thank you for joining us, and we have done this a couple other times, and this is always great that when we have you guys joining us and giving your presentations. I know this is a very useful process for our employees, the existing and new employees. We use these presentations for our training as an add-on, not like the main training, of course, but also we do communicate with our clients. They are able to understand the process in a better way. So that's why these sessions are very important. Muriel, you are going to do your PowerPoint, right?
I do have a PowerPoint. Yes, I can share.
If we can actually start with your PowerPoint, I'll save my questions for the end of your presentation.
Okay. It's saying I need permission to share my screen.
Right. You should be good now.
Okay, thank you. So I put together just a quick little PowerPoint on the team at United Medical, the collections team's workflow. So just to start off, I have here just a basic rundown of what the workflow is currently for the collections team. What the collections team does is they generate reports on the overdue patient balances for each client that participates in the collections process. After they generate reports to pull the overdue patient balances, they start a process that we internally call a pre-work process, which is basically just verifying that the balances are accurate, the patient has received sufficient statements, there are no current payments on the account, any little things like that that might, in essence, disqualify a patient from being sent to collections. Our goal is not to just immediately send people to collections. We want to give people chances, but then when those chances are done and over with, then we transfer the accounts over to the agency. But that's what the pre-work process is. Once we review the accounts in the pre-work stage, we then send the reports to the clients for their final approval. We do not send any accounts to the agency, the collection agencies, without the client's approval, so they have a chance to review it. And if they want to exclude any patients or they have any criteria or any questions, then we can review those together. After we get the reports back from the clients, we then start preparing the accounts to be transferred to the agency, which we just include the basic patient demographic information, the balances that are overdue, the dates of services, things like that. And we send the files over to the collection agency. So that's a quick little wheel of what the workflow, what the current workflow is for the collections team. And here I just go into explaining really quickly what the pre-work process is, which is what I basically just said earlier. We screen the accounts for final review and approval by the client. Again, ensuring that patients have received sufficient statements for their balances, and there are no special circumstances or issues on the account. And the other item that we do keep an eye out for is we want to make sure that there are no active Medicaid patients with overdue balances. Those we review separately with the client and with the team as well. And here again, just preparing the accounts for transfer, we just apply what we call adjustments into the practice management system in order to send the balances to the collection agency. So by doing that, in essence, we're shifting the responsibility of still collecting the balances to the collection agency. So that's why we in a way remove those balances from the system. So the patient is not also continuing to get statements from us and then also getting notifications from the collection agency. Aside from that, we also add alerts to the accounts, notifying anybody that can open the account. They can see when the patient was sent to collections, for what amount. And we also provide the phone number to the collection agency so that patients can be informed if they go into the office. And for example, the doctor's office can say, oh, you were sent to collections. This is the phone number for you to reach the collection agency to settle your debt. And again, any approved accounts from the client are transferred to the collection agency for further processing. For this slide, I just kind of want to quickly note just some other items that the collections team also does as part of their routine workflow. Aside from actually pre-working the accounts and sending them over to the collection agency, we also get requests and notifications, not only from clients, but from the collection agency themselves. Usually if a patient disputes a balance, then we get that notification from the agency and we provide any information that the collection agency needs in order to validate the balance is accurate. We also report any payments that patients may make at the doctor's office, or if they send us any payments, we report those information to the collection agency as well. And here's just a couple of the collection agencies. I just kind of wanted to highlight a couple of agencies that we currently work with Waterfall Revenue Group actually being one of our biggest agencies with the most accounts that we work with. So for my last slide, I just kind of wanted to quickly note down, why does it matter? So why do we do this? The longer a debt sits unpaid, the lower the chance of collecting. So that's why we actively try to work on the reports. We try to review the balances. We send, before it even gets to the collection stage, we send statements, letters, things like that, because we want to collect those balances for the provider's offices on behalf of the patient before the patients are even transferred to a collection stage or to a collection agency. Overdue patient balances also do affect days in AR because it is money that are owed to the providers that is just sitting and it's not being collected. So it does affect the days in AR overall. And again, patient balances are money that are owed to the provider. So any uncollected patient balances, the provider is not receiving for their services, which is another reason why we actively try to pre-work the accounts before they even get to the collection agency stage. And it's important for the provider offices as well to do as much as they can in the office to collect the patient co-pays, co-insurance, if they know, deductibles, things like that, before it even gets to an aging kind of stage. And that was actually it for my presentation. Kemal.
All right, Muriel, thank you. So I have a couple of points that I would like to make. Again, the collection here, in many cases, it may be misunderstood. It's one of those that we actually have, one of those terms that even for patients and for the practices, when we say collections, we also, as an RCM company, we collect, but we collect from the insurances. And we also collect from the initial collection from the patients, like co-pays, co-insurances. Your team sends statements. So our goal is to increase the efficiency of those so that patients wouldn't be at the point of collection at any given point. Now, the issue of many issues that we have with collection process is when practices don't have a standard uniform way of dealing with these types of accounts. So if, for example, someone who should be in the collection status, so our PM system is going to take that and then put it in the collection module. But then if you keep seeing the patients, then they will not be receiving statements for the new balances because they are already put into collection status, which is going to make, which is going to confuse the patients, which is also going to create a lot of confusion for the office, because those balances, once they're in collection, we put a write-off as a collection write-off for those. And when we have the collection write-off, then the office may not actually see the actual balances. So then you have new ones accumulating, and then now you are billing, you are seeing the patients with new visits, and you are billing them. You think that you are billing them with the new balances, but the system won't generate any statements.
Correct.
So then when we actually take a full action on the collection and put the patient actual collection, taking them from the module and then place them in the collection, then what happens is now they are upset because they're like, if I was in collection, why did you see me, or why didn't you send me new statements? And that's something that happens with us on a pretty regular basis if the practices did not adopt the standard procedures that we have in place, right? Correct. So our goal is to make sure that we increase the awareness of the system issues so that they can actually they can have a better understanding, and also it's also fair for the patients too. But we our clients are practices, medical practices, private practices, and financial sustainability is extremely important for them. So, and the collection piece is one of them. Now, what you and I, we know, once the patients are in collection, the practice loses 30% of that collection amount for the collection company, because those collection activities are expensive activities, and the practice already, especially these private practices like us, this is our bread and butter. And then every time we lose any percentage in these, not like, I'm not even talking about 30%, but even like 2, 3, 5% is a lot of money. But then if 30%, like Muriel, you know how some stores, they don't take Amex because I guess Amex is charging them a little bit more on the merchandise fee. That's like 0.02% the difference. Just imagine, like some stores are, some business owners are making decisions based on those little numbers. We are talking about like putting someone in collection and then losing 30% of our revenue, right? So this is why it's very important. And also, like, again, with the same standards that we talk about, the resource allocation, like how much time do you have to spend with patients who are not making their regular bills, regular payments. And I don't know if we covered this one, Muriel, but we should also talk about how patient-oriented, how much how patient-oriented we are in terms of helping the patients. So as long as there is a willingness to make payments, we are there for the patients, right? So like you do set up payment plans, even for sometimes small amounts, small monthly amounts. Can we talk about that a little bit?
Exactly. So, and it ties into the pre-work process that the collections team does as well, because as I mentioned earlier, if there are any recent payments or there's any communication, we see any communication from the patients that they're willing to pay their balance and they're aware that they need to pay the balance, we don't send those accounts to collections. As long as the patients are making attempts to pay on their balances, we review those. So that's also part of why we don't have such an automated process that the system can provide in order to transfer accounts to collections, because we want to look at every single account. We want to look at every single patient balance and consider their situations. But again, going back to your point, we need to see that communication and that information from the patients. And if they call us or they send us inquiries and they say, I want to set up a payment plan, sure, we can do that. We can work with you. Again, our goal is not to simply just send everything to collection agency, because yes, the provider offices do lose a portion of that balance at the end of the day once they are transferred to the collections. But that's why our goal is to do as much as we can prior to that collection stage. And if we need to set up patient payment plans with patients or work with them, we can definitely look into that and do that as well.
Absolutely, absolutely. Now, now there are a couple other things that we can do, I believe. So, and if you remember what we did last week, Sean and myself, we did present a session for our United Medical Clinic patients. And the reason we did that is because we wanted to increase the patient communication, patient understanding, and what our practice structure is. And one of the important things in those types of presentation is that what the practice do or what practices do for these types of things, right? So this should be communicated ahead of time in the beginning with the patient. So meaning that patients should know that they may be in collection if they're not paying their bills.
Mm-hmm.
Now, Muriel, you have been with us, is it 12, 13, 14 more, right? So you were in the old office. So the new office is going to be 10 years. So then, okay, actually, I can go with your age. You were 18 when you started.
Mm-hmm.
How old are you now?
I think I stopped counting after a certain time, but I think I will be 36 this year.
So so you've been with us for what, 18 years then?
If I started at 18, yeah.
Oh my God.
Or maybe I'll be 35 this year. I don't know. I stopped counting.
So it's been a long time, right?
It's been a long time.
You are still 18 in my.
Oh,
so
that's good.
Here's the thing. So when we look, if you remember, the reason I was making reference to the past, we didn't see big deductibles, big co-pays in the old days. So right now there are some PCP, primary care co-pays that $40, $50, $30. So now average 99213 or 214, probably let's go with $100, $110 off for the average. I'm going with the Medicare averages. 92 for 99213 and then 130 for 99214. Let's go with 110, right? If this is an insurance company that has a huge deductible or copay, $40 out of 110 is almost 35% of the total. So if you don't collect this at the time of the service, we don't have those types of margins. Our medical practices don't have those types of margins. So now they lose that from the beginning. Now, in order to get that, they have to do so many different steps, like your team with the number of statements that you are sending. People have to prep them again and again and again. And finally, we put them in collection. If we get that at some point, we are going to lose 30% of that.
Yep.
That's a huge responsibility and liability for practices. And that's why it started with you when I think you were the person on the RCM side who worked with me on the collection module. So we built the database together, right? So then we can actually give the most accurate data to the practices, so then they can take an action. So there's that part that I'm hoping that some of our clients are watching this. So I want them to hear this again and again. So all that process, all those reports, we spend countless hours. And unless we take an action on it, it won't go anywhere. And in from my perspective, the way that I see is everyone should have their accountability and responsibility. This is the practice, this is the patient, this is the RCM company, and this is the collection company. So we want to make sure that patients are aware of what they are getting into if they don't make their payments. So there's also this legal part of it. Many people don't actually know, Muriel, we should also talk about that a little bit. So, and again, some of our new employees may be watching this, so they should learn this. So there is a legal limitation for medical practices that we cannot charge less than what Medicare fee schedule is for anyone. If, let's say, so this, I'm going to let Sean in so that we can actually pick on him. So, well, because Sean's on the business development side, he may or he may not know all of these. So, but we are going to use him as a sample patient. So, if he didn't have insurance, and then if he comes to one of our offices, our fee schedule for him for his visit cannot be less than what Medicare charges for that visit, what Medicare pays for that visit. So let's say if you're going to charge level 4 established patient visit, that's $130. At a minimum, I have to charge that. If I take less than what Medicare is paying, that's illegal. Because the federal government is saying that, well, if you are okay to take less for this service, why are you charging me? Why are you expecting higher amount from me, which makes a lot of sense.
There goes my barter approach.
And
I'm gonna try to talk you down to a lower rate, but
so then there we go. So see, it can go to that because remember last week we also discussed this, and I keep you'll probably hear me saying this so many times. Medical practices, healthcare industry is one of the most highly regulated industries ever. So we have so many different restrictions that we are not, some of them make sense and some of them don't make sense, but it doesn't matter what makes sense and doesn't. So if someone makes this as part of the law, that's what we have to follow. And the CMS, Center of Medicare and Medicaid, is extremely strict with regulations. So we have to follow that anyway. So meaning that, so if you are not going after these balances, so then you still have liability for the standard practice that you have.
Correct.
That's why it's important for practices to adopt the standard process for collection module. So, and I know we are going to share some of these events with the practices after the live session. So I want to make sure that they hear certain things for them, what's highlighted for them. So there are legal liabilities, legal responsibilities that we have, and then we have to do the right thing from that point and keep the practices out of trouble. So, and Muriel, maybe you mentioned this, or maybe you didn't, but we are not, we do not have a collection company internally. We work with a third party, right? So there is no conflict of interest from our standpoint. In fact, we lose money when, as a billing company, as a revenue cycle management business, when we put patients in collection, we lose our own percentage. So it's not our best interest. So sometimes practices are saying that, well, you go for the easy collection, then you don't do the hard work. That's not true, because when we put those people in collection, we lose our revenue. So, and then once the patient makes the payments to the collection company, we don't get paid.
Exactly. And we don't charge anything extra to do this process for the clients either. And when the balances are paid with the collection agency, we don't get anything from that, of course. So yes, we end up losing on our end if we do have to transfer accounts over to the collection agency, but that's not really in our minds, and that's not really our we don't think about it that way. We want to do what's holistically good for the practice and of course for the patients as well. So yes, we do end up losing if we do have to transfer accounts to the agencies.
You know, one other thing that I'm thinking that we should also mention, the process that we have for some of the practices, how they utilize QuickBase for their prep work as the pre-visit activity. And then how we can actually kind of like, you know, how my approach always is go to the root of the problem. And the root of the problem is, how are these balances coming? Where are they coming from? So they're coming from While, of course, patient's plan has a high deductible and high copays. So then if the front desk does not collect these copays, that's one of the problems. But then if the front desk doesn't also have a follow-up for pre-visit to get the, to prep the patient for, okay, you have X amount of balance from your prior visits. When you're coming back for this visit, you need to come prepared. And if that part is missing, that's also affecting the high collection amounts, right? So we have to kind of also emphasize the proactive approach that you should be taking for these balances, because if the patient, if we kept seeing them after we put them in collection, or if you don't prep them as they are coming back for a new visit, then you are going to actually, that amount is going to accumulate, and then at some point it's going to be out of control. So, and this is a big number, right? So we are not talking about like small numbers.
Exactly. And I actually want to add to your point too, Kemal, that how the practices notify patients on what their balances are can impact whether they're successful in collecting or not. So for example, if a practice, let's say the front desk says, oh, you have a balance, do you want to pay? Of course, your initial inclination is not going to be to pay, right? But if a front office says, oh, you have a balance, how would you like to pay today? That can lead your success rates higher than if you were to just say, do you want to pay? So again, just how the front office notifies the patients, how they word it to the patients is also impactful.
That's really important, because if you give as an option, would you like to pay today? Your answer is, okay, how much are you going to pay? Is different approaches, and you're absolutely right. So one of them is more effective than the other one. But again, like patients need to understand that this is their responsibility. And the practices need to understand that they need to keep the patients accountable. So then we can eliminate some of these high cost revenue loss for medical practices, because we are already, as private practices, we are already struggling with with these nonprofit hospital systems. They get a lot of help from the government, state and the federal government, while we are not, and we are still, we have to be able to do the same work, and we have to provide the same service. So because of that, I think it's important for us to be more efficient when we are seeing our patients. So Muriel, as always, thank you for joining us. This was there's always some new stuff that we are learning. I know we have done this a couple other times, but if you go back and watch some of them, it's never going to be identical. So there's always new stuff that we either add or we maybe say it in a different way for some others to understand better. So, and then I do appreciate for you guys supporting these events and taking your time off and from your work and then do this. So thank you for joining us.
No problem. Thank you for having me, Kemal.
Of course. Bye-bye.
Bye-bye.
All right. So, so we have a different topic today, which we were trying to cover in the last several weeks. So let's start with a good congratulations to all of our medical practices who were part of the MSSP contract. MSSP is Medicare Shared Savings Program, and United Medical ACO did probably, like, this was our best year or program year 2022. So physicians, providers, practices, medical staff, United Medical Central Office, everyone who were part of this, congratulations. And we did it. We are one of the best ACOs in the nation. We are number 17 out of 482 ACOs nationwide. We are number 1 in the state of Delaware based on our savings rate. And this is an important achievement for us to be able to be at, because we are from the MSSP standpoint, this is our only MSSP in the state of Delaware, so we don't have like 20 of them. So I mean, we have other ACO programs in our Delaware platform, but in terms of the Medicare itself, like this is our only one. So there are some multi-state ACOs out there. You know, they have more resources and everything, but we did this on our own without getting any help from anyone. Pure hard work and a lot of struggle. So we finally made it. So again, this is a very important achievement for ACOs like us, private ACOs competing with hospital systems. So we crashed 2 of the hospital systems in the state of Delaware. We do that problem pretty much every year anyway. So now this is kind of like, because it's a straightforward number, statistic, and Sean. So like I can easily say what this is and what this is not, right? So, but one thing that we probably didn't get a lot of credit up to now is we were always the least expensive ACOs without compromising the quality. So this is from the beginning. So this is why I was thinking that we can maybe talk about the Medicare share savings a little bit, and then we can look into some of our numbers. So now Medicare, as we all know, this is a federal insurance, federal program. And then they started share savings programs in early 2010s. So I think there was a Pioneer ACOs first. John Donnelly can correct me if I'm wrong with those. So we were going to be part of it, but it was too early for us. And then in 2015, MSSP model formed, and we are one of the first ones in Delaware. Now, the challenge was this was an unknown. So now let me actually talk to you about some of this, why this was an unknown, and if it's an excuse or not. Like, we are not using this. We just didn't, like, what we knew is we had to be good from the beginning, Sean, right? So we didn't care about, like, actually not like we didn't care about, we didn't know, okay, how to make it in the beginning, because it was not clear. But some people did though. So if they were in the government, federal, state offices, if they were employed, or if they already were part of those programs, if they were the advisor to the president for the healthcare, they knew what was coming. We did not. What we were doing, our goal was not to be behind from any other ACOs. Remember, we have our EMR system, EMR logical domain, is set up in a very unique way. So we have several different practices under one domain. So that's a very unique setting because we don't have the same ownership. So we had that before the ACO. So that's something that we started all the way from 2002, where we were limited to share information. So that you could only share allergies, medications, and problem lists and the demographics. This is until 2012, perhaps. So then Medicare, the government changed their approach. They said sharing is caring and it's better for the better care, because why you are sharing it is because you are actually you are clinically integrated. So then you are making multidisciplinary approach. So therefore, we knew that what we had was golden for us. So we had to kind of build on it. And when these programs came, Blue Cross in 2014, they did not take, they didn't recognize us as an ACO because of the different ownerships. Then when Medicare approved us in 2015, so we were federally approved, recognized by Medicare as one entity. That changed that pretty much changed everything. That was a game changer for us, because when federal government says this is one entity, Blue Cross couldn't say no, you are not. So then that opened up the doors for us. That's why we have now those 8 ACOs, which you are day to day, you are part of the management of those ACOs with the case conference, case reviews, and everything else that we do. Our meeting last night with our providers. That's all how it started. Now, I don't want to lose the focus here, but one really important thing, and then this maybe even sometimes even you guys may forget, there was an ICD-10 upgrade. Well, ICD upgrade. So it went from ICD-9 to ICD-10. So the risk scores, which we were very much not knowledgeable of, they were all guided by, or they're driven by the ICDs. ICDs are the diagnosis. So that if you put the patient, like their A1C is controlled, but they have diabetes, like they have diabetes and their A1C is not controlled. If you use E11.9, you are not getting enough credit for the work that you do. If you use E11.65, then you are getting a better credit for the expenses on behalf of that patient. So this was in the middle of that change when we went live. Now, that means everything that we had with the benchmarks was based on ICD-9, 2013, 14, and 15. Mm-hmm. But then our program year was on ICD-10.
Yeah.
So there was a huge gap.
Clearly.
You follow me on this, right? Yeah. So that's why, although we were so inexpensive, which was a huge problem for us because we were not competing with anyone else. We were competing with our own numbers. Yeah. So you have to be minimum 2.7% better than your own numbers with the benchmark. So our benchmark year 3, 2015 was $8,900. It was the least expensive ACO, but it was 25% maybe less expensive than the Christiana system. Mm-hmm. So for the outpatients. So now we thought it was a good thing in the beginning, thinking that we were going to be compared with the others. That was not the case. Mm-hmm. So we were going to be getting this minimum savings rate in order for us to get any savings. So the A- student going from A- to A is not getting anything. So the D student or the F student going from F to C-, you make millions. And that's a lot of ACOs, MSSP ACOs made money. Is it fair? No. Is it real? Yes. Is it business? Yes. So then can you change it? No. So then you have to kind of learn how to master the system. And that's what we have done. So because 16, 17, 18, and 19 first half, that was the first term, and 19 second half, 20, 21, and 22. So this is, okay, 17, 18, 19, 20, 21, 22. 7 full years already done. So we are in the year 8. So in that 7 years, first 3 years, we made nothing. And we spend millions to be able to have that machine that can actually run so smooth for the year 4, 5, 6, and 7. So that's the results that we are seeing today. Now,
I was going to say, an analogy that kind of remind me of when it comes to like sports, how you always hear sometimes they're like in a rebuilding year. So like a team who maybe, I don't know if it's not the same, but traded away their best players or something, like they're not expected to win the championship that year, but they know that what they need to do that year is be able to figure out their approach for a couple seasons down the road, where now we have figured out our method and what techniques we're able to perfect. That way we know by the time 3 seasons from now, or as you're saying, 3 years, fiscal years, we're ready and we have it all perfected now that we're able to put it into effect. So maybe that's kind of helps somebody understand like those.
That's a really good analogy. So that's where you being the quarterback probably is helping you to have that analogy, but that's exactly how it is. So we knew that we weren't going to make it because we were already in a really good position with our numbers. Right. But then there were ways to learn coding and the risk scores.
Stuff still had to be done.
Yeah, and then support our practices from the medical, from the central office. That's, I mean, I know you guys are kind of on the newer side of our organization when Donna Dunkel started in 2015 until probably 2017. She and I, we would be in meetings every day, all day in some days, but at least like probably 3 to 5 hours we would be spending to build our population health system, what we have today. So then, because now it's like, you know how smooth it goes when we do the case conferences,
Exactly.
but that's built with a lot of hard work that we have throughout the years. So now, although, you know, when we lost first year, I was not able to digest that well. So I had to kind of just maybe cry a little bit, cry in a business way. So then what that is I had to write an article. So the article was No Kids Left Behind, titled No Kids Left Behind and No ACO Left Behind. So no ACOs or MSSPs left behind. So people who are interested in that can actually find it either on my personal blog or my LinkedIn page. Because we were just complaining about how unfair this whole system was.
Yeah.
So there was, I remember very clearly, when our cost was $9,200 for the first year, one of the ACOs from Florida at $27,000, they improved from $27,000 to $22,000. Still like 2.5 times more expensive than us. They made like millions. And I was pointing them out because this is a public data. And they kind of called me a hater, but it wasn't a hater. I was just trying to point out the issues because, well, yes, I understand that we need to bring those practices, those organizations up to speed, but we have to also protect those practices who are doing really well. So you cannot discourage us by almost like penalizing for being good. So that's how the system worked in that. Now, since we are talking about the MSSPs, and I want to just say this only in this session, and then I don't want to ever maybe mention this, but one of our biggest problems is I was telling you openly about our unknowns in the beginning, but this unknown wasn't the case for every ACO, every MSSP in the state of in the United States.
I think I know this story, but
so, like for example, one of the ACO's CEO was the healthcare advisor to Obama's administration, and this was right before they started their ACO. Then he left that position, and then he started the ACO. They raised capitals. You know, hedge funds supporting them, so they raised like 300-400 million, and they went just randomly in different states. We have one in Delaware. So and then initially I was thinking like, why would anyone pay money or risk money? Because we couldn't risk money knowing that this is our organization and we know every ins and out of the practices. But then someone can actually put millions. So then, because they were raising money. So that means there are some investors who are comfortable putting their money. Why would they be comfortable? Because the guy was Obama's advisor, right?
Yeah.
So how is this happening in the country like United States, one of the greatest countries in the world? Like the law is everything for us. Yet we have 6 months ago a healthcare advisor. Today, healthcare private capital, you know, company that they're just you know, increasing. I mean, raising so much amount of money. Same company. This is the CEO. So when I go to their president, so their president worked for the CMS. So this person led the Department of Health and Human Services Regional Extension Center project for so many years. So then I go one more to their chief policy officers. This person is prior to joining this other ACO was the center of Medicare at Center for CMS Services. So he was a director and deputy administrator, and then their chief medical officer is part of the Department of Health and Mental Hygiene Primary Care Information Project. So and then their chief performance officer is the U.S. Department of Health and Human Services. He was a director there. So do I need to go more? So how is this legal?
Yeah.
And why is this allowed in this country is amazing.
That insider knowledge, it's almost like they were, involved in setting up the way it's going to be graded. And it's like, we know the structure behind how you're going to be evaluated, what's obviously what technique is going to work tenfold compared to where people might struggle, and having that, and now you're going to say, all right, now I'm going to go compete with other people who don't have this same background.
It's just unfair, right?
Yeah.
But it's the reality. So now, is this information readily available for everyone? Well, if you are looking for it, it's there. And if you're also questioning, it's there, because many people, they will see it as like, oh, look who they hired. No, they're actually investors. So these guys are not just employees of this organization. Now, of course, our today's topic and focus is celebrating our success nationwide. And also, I'm also taking maybe extra pride on this, where we did this on our own with no help from anyone and almost zero knowledge in the beginning for the how the ACO structure works. So we have a really good understanding of clinically integrated organization. We mastered that, but we did not have the other issue of like knowing exactly how you are going to make it, because it's all about the diagnosis, what you are sending, what you are not sending, how you are sending. So, and if you did that in the beginning, so if you were part of developing that program, so we could have made a lot more.
It would be a big head start.
Right. So this is really important, and I am extremely proud of our physicians and providers and medical staff, and thank you for everyone joining us and making this possible. Now, speaking of the ACOs, we should maybe take a couple minutes to discuss. In the state of Delaware, we have 3 Medicaid ACOs, Health Options, Mary Health, and Delaware First. We have commercial ACOs, Highmark, United Health, and pretty soon Aetna is going to be final. And also we have Medicare Advantage ACOs, Humana and United Medical and Aetna. So pretty much 85% of our total practices are under a value-based contract, which is kind of like the dream place to be in, because we are in one EMR system with Oracle Cerner PowerChart, which is a great partner for us. They have been supporting us with our ACO initiatives and helping us to improve our clinical challenges, and having Oracle Health on our side, helping us with all these day-to-day challenges. It's also extremely important. So we do want to acknowledge their support, and we appreciate what they have done for us throughout the years. So I think that's all we have for today. Next week you are off, but we have our is it the diabetes?
So yeah, you actually have Dr. Lakido to be joining, going over the most common chronic conditions seen in the pediatric population. So she will be on also with Donna for a clinical session. It's been a little while since we had one of those, so it'd be good to focus in.
And then we have the political series that we started. So we have.
Yeah, so we have Senator Kyle Evans Gay, Senator Sarah McBride, Lisa Blunt Rochester, current Congresswoman running for U.S. Senate. We also have Coyote Abagunde running for State Insurance Commissioner.
And he's going to be next month.
Yeah, he's supposed to be beginning to mid of October. And then in January, running for U.S. Senator, also Dr. Michael Katz.
We have Sarah McBride, Lisa and Rochester, and
Bethany Hall.
She's going to be I'm going to try to have them in December. We are going to try to have them in December, but we wanted to finish everyone else prior to them. So hopefully we'll get through those, and then we'll start a new session, new cycle, with whoever's left in 2024 from the initial start. So we were at this Rochester event last Friday. So I went to so many different political fundraising, but that was your first. How was that?
It was good. The wine was good.
Mine was good, but what was the overall your expectation and what
I mean,
left it?
I wasn't expect like I didn't know what to expect. But I mean, again, I think the key for Delaware is, since it is a smaller state, having strong network behind, and those connections is definitely going to be a driving point regardless of who's running for their campaign. So I think starting early and getting ahead is definitely a key factor in having a successful campaign. So
we were able to also finalize our event with Senator Kyle every day. So then we saw Tom Carper. That was kind of interesting for us to see someone who actually kind of leaving the seat for the person who's now running for. So that's not, you don't see that a lot. Right. So that was a very small gathering too. So I thought it was it's important for us to see those types of things. And who was that lady from Florida? I want to say
Jerry,
because they called his name so many times.
He was, I would say, one of the representatives from Florida, but she's the chief of police there.
So Val Demings.
Yeah.
Okay. Yeah. She was pretty strong.
Yeah, she had I think her speech was almost as like impressive, if not more so than Lisa. So
she was good. All right, so we'll bring those to this event, and we'll be the voice of medical practices in Delaware, and we'll be back next week with Dr. Jennifer Latito and Donna Gunkel. Thank you everyone for following us and watching us. Bye-bye.